Hello, good evening, and welcome to this European Federation of Internal Medicine Young Internists webinar at the start of 2024. Thank you very much for joining us this evening. My name is Anda Balarga. I'm currently a cardiology trainee in Edinburgh, Scotland. I'm here on behalf of the Royal College of Physicians in Edinburgh, and I'm delighted to introduce my co-chair this evening, Dr. Joanna Bregelman, who is an endocrinology resident and works at the hospital in Essen. This evening, the topic is bone health and calcium homeostasis, with concentrating on malignancy. And we have proposed to have two speakers this evening. Unfortunately, our second speaker is unable to join us this evening due to a last-minute emergency. However, we will be recording the presentation. The video will be available online at a future date. A bit of housekeeping before we start with the talks this evening. So please supply any questions, and you can type them directly on Zoom, and we'll be able to answer these questions during the question and answer part of the session after the talk. Just to say that we have put off all the microphones in the background, so we'll not be able to ask any questions during the presentation. And yes, welcome and enjoy this evening's webinar. Without any further ado, I will pass on to my co-chair, who will introduce our first speaker.
Thank you, Anna, for that introduction, and also a very warm welcome from my side. I'm very honored to introduce our first and today only speaker, Dr. Ieva Ruza, who is an internist and endocrinologist at the Riga East Clinical Hospital in Latvia. And she focuses in her work on calcium metabolism and sarcoidosis and autoimmune diseases, and likes an interdisciplinary approach to those problems. And she has been a member of the EFIM family for many years, and also served as a chair previously. So I'm very happy to hear your presentation, and hand over to you, Ieva.
So, dear all, good evening, everyone. I'm very, very glad, very humbled to be invited to do the webinar. With the focus on calcium and bone metabolism in malignancies. That's the topic I absolutely like, and I more and more frequently I'm dealing with these problems on daily basis, because I'm consulting many people with oncologies lately as endocrinologist. Unfortunately, this time I'm due to the last-minute emergency, as Anda mentioned, I'm left alone with this webinar, and you will be able to see, to listen to both presentations anyway later. So my topic is a secondary hypercalcemia of malignancy. Talking in general, because our webinar is focused on the internists and particularly younger in training colleagues, giving the baseline of the knowledge of the topic. The calcium is very, very tightly regulated electrolyte. So we are talking about total calcium in millimoles per liter between 2.1 2.55. We usually use millimoles per liter. For those who are using milligrams per deciliter, feel free to calculate, multiply or divide with 4 if those units feel more familiar to you. When we are talking about ionized calcium, that's approximately 40–50% of the total units. And depends what would be your routine testing in your hospitals. In our hospital, we are usually doing total calcium. In some cases, of course, if you are taking astro analysis, then ionized calcium might be immediately available. And in any case, more frequently, we need this in hypocalcemia and low calcium values, but also that might be necessary when we are dealing with elevated values. I would definitely suggest to correct calcium values to albumin levels. When we are talking about hypercalcemia, that's about excess over 2.5 millimoles per liter. therapy would be mandatory if it's higher than 3 millimoles per liter. Of course, if there are clinical symptoms and some relevant situation, you might start therapies earlier by 2.8, 2.9 millimoles per liter, and so on. But the stratification might be on 3 millimoles per liter. Severe might be considered if it's up to higher than 3.5 millimoles per liter, and crisis when we additionally have some neurologic symptoms or cardiac arrhythmia, or above 4 millimoles per liter. Here is just a schematic picture of the same story. The treatment might be necessary if calcium values exceed 3 millimoles per liter or 12 milligrams per deciliter. In a very basic, what we are talking when we are talking about clinical signs, the English-speaking colleagues definitely know this mnemonic. For those who don't use English in their daily practice, remembering that might be a bit struggle. Nevertheless, stones, bones, moans, groans, and cardiovascular problems. So I never have managed to remember this immediately by myself. But when we are talking about stones, we are mostly thinking about kidney stones, about nephrolithiasis. And this is, I have a few patients in whom there has been repeated episodes of kidney stones, and then just afterwards, the elevated calcium levels have been found. Bones, we are talking about secondary osteoporosis, or in nephrology, osteitis fibrosa cystica. That's a relatively frequent thing. About gastrointestinal moans, that might be pretty difficult because the symptoms are very general, difficult to detect. But nausea, vomiting, constipations, very, very rarely pancreatitis or peptic ulcer disease might be the reason. For psychic groans, there might be confusion, lethargy, fatigue. And to my big surprise, I actually had one patient who was hospitalized with the only and the one symptom of confusion, thinking about the stroke initially, but later on discovered having very severe hypercalcemia. From cardiovascular symptoms, short QT might be detected. That's the most frequent one, or arrhythmias. That's why when we are talking or working together with cardiologists, it's not just the thyroid. I occasionally ask to look also for calcium values if you are dealing with unclear, unknown atrial fibrillation or paroxysms, frequent unclarified paroxysms. Talking about the reasons or the etiology of hypercalcemia, of course, the most likely we know that it's primary hyperparathyroidism. There might be not so frequent causes as familial hypocalciuric hypercalcemia, tertiary hyperparathyroidism, and the second largest part is malignancies, namely myeloma, PTH-related protein-mediated malignancies, or bone metastasis. And the third large part is granulomatous disease or lymphoproliferative disorders. The last one, more frequently seen in clinical practice, might be the exogenous vitamin D overdose, particularly in dialysis patients. So when you see hypercalcemia, think of the frequent thing first: primary hyperparathyroidism or malignancies. And the third one, lymphoproliferative disorders. Talking about the differential diagnosis, there are many, many different algorithms. And of course, many clinics have adapted their own algorithms. But very often, the best way how to start is try to figure out what is the PTH, and based on PTH values to stratify how to proceed. Do we think about primary hyperparathyroidism as the most likely reason, or are we dealing still with some potential malignancy or another pathology? And if we are measuring low or suppressed PTH, the next steps would be checking vitamin D levels, thinking about not the calcidiol, but calcitriol. And in hospitals or in clinics where it's possible, PTH-related protein might be detected. Unfortunately, not in Latvia, but still it's a routine test in many countries. Or thinking about other diagnoses as exclusion ones. So through PTH might be the stratification, should we think about more benign or more malignant pathologies. Few words about PTH-related protein. Occasionally it's called peptide, but peptide is a very small molecule. Hence, protein would be more appropriate name for this molecule. This resembles PTH. In one part, as you can see in a picture, binds to PTH receptor and simulates PTH biological effects. And there are a few isoforms available or seen in the body. Mostly, PTH-related protein is secreted by tumors as part of the malignancy, hypercalcemia as a paraneoplastic secretion. However, there are definitely some data that, for instance, in sarcoidosis patients, there also granulomatous tissue might secrete PTH-related protein and exert all the typical hypercalcemia effects. And from clinical practice, occasionally we might see similar issues due to PTH-related protein secretion in placenta. In those pregnant ladies, we mostly see PTH suppression and calcium levels might be still within the normal limits, but that's also a physiological process. Talking about malignant hypercalcemias, I wanted to share a very small clinical example, clinical vignette about a 55-year-old male patient who was initially complaining on cough, fatigue, hoarse voice. And at some point, he had been consulted in outpatients, and chest CT revealed rather huge left side bronchocarcinoma. Lymphadenopathy was seen, and radiologists describe 6-segment metastasis. And due to this finding, the patient was sent to hospital where bronchoscopy biopsy was done and confirming histologically non-small cell squamous cell bronchocarcinoma. Unfortunately, patient refused any operative therapies. Chemotherapy also was offered, but it turned out that the patient never visited the oncologist until next year, next September. And when he was appearing to oncologist, his complaints were about fatigue, nausea, obstipations, cough, dyspnea, and occasional melena. Actually, melena was the disturbing symptom. I cannot remember precisely the details why it was, but this was the reason why he actually went to oncologist more than the lung symptoms. And now the chest CT revealed left side bronchocarcinoma has grown nearly double in size, and mediastinal lymphadenopathy was seen additionally with bilateral lung metastasis up to 5 centimeters in diameter, as well as bilateral axillary lymphadenopathy. In abdominal ultrasound, no distant metastases were seen. And when the first biochemical tests were done, this is a direct screenshot from the Latvian. Nevertheless, it's the most necessary test results are internationally recognized. Its calcium level was 4.59, where the upper limit was 2.55. Creatinine was elevated with GFR about 37 milliliters per minute. And intact PTH was absolutely suppressed, 4.9. And this combination, elevated calcium and suppressed PTH, this quite directly demonstrates that we need to think about malignant hypercalcemia. What was done for this patient? Despite relatively low GFR, after hydration, he received pomidronate twice, with some three-day distance between the both infusions. Due to low potassium, he received also potassium chloride intravenously, and of course, before all this therapy, saline was given. In the dynamics, the condition improved. Calcium was reduced to 3.2, 3.07. And so the final diagnosis at that time point was non-small cell squamous bronchocarcinoma with hypercalcemia of malignancy. Paraneoplastic ACTH secretion was initially suspected because of lowish potassium values. However, patient refused from additional investigation, and there was no time to check that no cortisol ACTH was taken. And patient also refused palliative therapies and later zoledronic acid intravenous infusion that could be part of the oncology palliative therapies. Discharged, and only from the patient database we found out that he passed away 2 months later in December 2016. So it's like 2 months after this hypercalcemia episode. When we think about hypercalcemia, it's the most common cause in hospitalized patients. Depends from literature, it's between 2 and 40%. In general, most literature sources cite about 20% of incidence. And among all cancers in female, breast cancer is the most common malignancy, and it has the highest prevalence of hypercalcemia. If what we know from literature data is that 70% of patients with breast cancer have metastasis in bone, and 10% of them will have a hypercalcemia at some point due as a complication. So it's very, very frequent thing in a frequent malignancy. I won't go in details on this slide, but as I know it will be available in recording, so you might be able to stop and see the literature source. I left these rather busy New England Journal of slides with the citation, so you can go to this publication and see more details by yourself. Two main mechanisms are seen. Local osteolytic hypercalcemia, that's more like in breast cancer, or humoral tumor hypercalcemia. This is more typical for squamous cell cancer, like PTH-related peptide release. So, and occasionally both mechanisms like humoral and local combine themselves. This is another picture from the same publication, very detailed documentation of the pathology, pathophysiology, how these mechanisms, activations are happening. Just very briefly underlying what happens there is a humoral mechanism. Its main driver is PTH-related protein, increased PTH occasionally, and increased calcitriol, activated vitamin D directly. And the second mechanism in the right side, that's osteolytic mechanism, where usually bone is resorbed, and there might be local destruction by metastasis or humoral factors influencing the mechanism. To my rather big surprise, because we usually, when we deal, we are talking with hypercalcemias more in patients with different squamous cell cancers. In many patients I have seen in lymphoma, lymphogranulomatous disorders, and we don't see so frequently, but it's also described the same mechanisms running in leukemia patients as well. They might be paraneoplastic hypercalcemia, the same mechanisms, paracrine or endocrine. And here is one scheme, how very simplified we might check what we have available. Calcium values are always elevated, and depending on phosphor levels, what are we thinking about, humoral or destructive osteolytic hypercalcemia, or should we think about calcitriol driven mechanisms? And in all of these malignant situations, PTH is always suppressed. Vitamin D levels might be formally normal. And of course, in this calcitriol-mediated hypercalcemia, calcitriol is usually elevated. And in humoral, if it's possible to detect, PTH-related peptide could be elevated. Just to underline and give the publication to the citation to some article that underlines different intersecting etiologies. So of course we might think that in some oncologies, some malignancies, one mechanism is dominant one, but very frequently there could be the, say in myeloma, there might be both endocrine paracrine or the humoral or osteolytic mechanisms. There might be combination of both mechanisms. To summarize treatment, I've used this slide. I will go to the more frequently used agents separately. I won't touch from this slide, I won't touch gallium nitrate. I tried to see some relevant publications, but as far as my knowledge, the gallium nitrate, because of nephrotoxicity, was withdrawn from the USA market already in 2012, so it's too long a time ago. I haven't seen any decent European publications, and the only trial, randomized trial, was from 1988, so it's way too old, and so we don't use currently or think about gallium nitrate as a frequent option for treatment of hypercalcemia in malignancies. And hydration, bisphosphonates, steroids, denosumab might be the ones where I'm going to focus on. So first-line therapy always for hypercalcemia of malignancy is fluid resuscitation, and we always go with a saline because of its definite efficacy. And dehydration could be due to hypercalcemia, so the first target is to restore volume, and the second, we definitely need to replete people in fluids just to avoid any further hypercalcemia, rebound hypercalcemia. In case if the patient is taking, we need to stop thiazide and lithium intake. Calcium restriction is always advised. It's very shady, but so it's difficult to control. But if the patient reports that he has used some calcium-containing supplements, that would be the one thing to ask him to stop, at least currently withdraw. Dialysis is not frequently used, but dialysis might be emergency therapy if there might be too much fluid overload after hydration. Calcitonin. We don't use calcitonin in our practice. It's considered relatively weak agent with a rapid onset, and there are described combination therapies with calcitonin and corticosteroids just to prevent typically described calcitonin tachyphylaxis. So allergy is a very, very anaphylactic reaction is a very high risk in patients who might use calcitonin. Glucocorticoids, definitely that could be the part of the therapy, but in case if there's an overproduction of calcitriol, these are calcitriol-driven mechanisms. And bisphosphonates are otherwise mainstay after hydration. So regarding the bisphosphonate therapies, the first were etidronate was introduced in malignancies. Pamidronate and zoledronic acid, those two have stayed currently. Intravenous administration, that's the benefit, and response rate depends on the mechanism and depends on the agent, is between 2-3 days. Shorter administration times of zoledronic acid could be available. So pamidronate usually takes 2 hours to administer, while zoledronic acid is infused injected within 15 minutes if necessary. And the main limitation for bisphosphonates for zoledronic acid is severe renal insufficiency. Theoretically, in malignancy, that would not be that important issue, contraindication. However, we always need to think about dental health to prevent osteonecrosis of the jaw. And I'm not a pediatrician, but in pediatric malignancies, the dosage is weight calculated, 0.5 milligrams per kilogram. There's another bisphosphonate described, not bisphosphonate, the rank ligand inhibitor. Denosumab is described for malignancies in hypercalcemia. And this is more recently discovered, and more publications are coming up of its efficacy. It's subcutaneous administration with a response rate of 9 days. No dose adjustment is necessary. And another big benefit is that it could be given also in stage 4 and 5 kidney failure patients with kidney insufficiency. Then the main risk is developing hypocalcemia. However, if there's the GFR is low, this might still give an opportunity for those patients. And in some trial, it's 2015. However, it was discovered it's more efficacious than treatment with zoledronic acid in delaying or preventing hypercalcemia of malignancy in advanced cancer patients. So that's definitely denosumab might be used in such people. And that's more detailed data from the same trial I mentioned was more efficacious than treatment with zoledronic acid, and 37% reduction in the hazard ratio compared with zoledronic acid, and reduce the risk of recurrent malignancy, hypercalcemia of malignancy by half. So it's rather good effect. In countries, if that's opportunity to use, that would be a good opportunity. Cinacalcet is usually leads to downregulation of PTH and decline in serum calcium levels. Mostly that's used in inoperable parathyroid cancer patients, those who have elevated PTH levels. And there are no currently available clinical trials for other types of malignancies. So it's known as oral administration. It's well tolerated, maintains serum calcium levels, while the other therapies might be applied. And you might check there's 3 different articles investigating these cinacalcet effects. Two large screenshots or the large tables, impossible to go through. Basically, just summarizing what I already told about the treatment options from New England Journal of Medicine about fluid repletion, furosemide, yes or no, calcitonin, bisphosphonates, denosumab, steroids, cinacalcet, and dialysis as options. So to summarize, the cornerstone of therapy would be intense hydration, so fluid repletion, followed by intravenous bisphosphonates, preferably zoledronic acid because of the speed. Glucocorticoids could be used in steroid-sensitive malignancies and the ones driven by calcitriol mechanism. Denosumab treatment was proven to be more efficacious than treatment with zoledronic acid. And in case of persistent hypercalcemia of malignancy, calcimimetic cinacalcet could be an opportunity. And I found an article where the future molecular target PTH-related protein-related antibodies are discussed but I think it's still in the future. Very briefly mentioning when talking about hypercalcemia, and I will show a very benign case, but still demonstrating the tests, how it might appear, because this patient initially was had differential diagnosis between the sarcoidosis and lymphoma. And histologically, it was confirmed to be sarcoidosis. However, he refused any therapies by steroids and went to very sunny vacation in Spain, activating his granulomas, definitely, because in sarcoidosis, it's not recommended to be in the sun. And when he returned, his GFR was only 30 millimoles per liter, calcium levels were 3.9. And despite being in a sunny climate, his vitamin D was very low because sarcoid granulomas were massively secreting calcitriol. And this calcitriol-driven mechanism paradoxically suppresses PTH. This is intact PTH. And if there would be available PTH-related protein as a biochemical test, of course, this PTH-related protein would be elevated in this patient. And there were bilateral hilar lymphadenopathy, also visible in a CT scan, increased here in a CT scan. And after these tests and clinical picture, patients still decided to go with the steroid therapy under control of pulmonologist at that time point. And just underlying the mechanism, so this is what we all of us know as this is absolute basics. We get vitamin D and 3 either by foods, by nutrition, or through the sun, through skin. We get 25 hydroxy vitamin D converted in liver, and as a feedback mechanism through kidneys by 1-alpha hydroxylase, calcitriol, calcidiol hormonally is regulated. If there's excess, the mechanism balance goes to 24-25 dehydroxylase and excreted with urine as inactive mechanism. And in how I usually describe in sarcoidosis, this is not exactly malignancy, but a very similar idea. It's like paraneoplastic, like paracrine. You have your own large physiological secretion, but if there's active disease like malignant or sarcoidose granulomas in this case, you have additional paraneoplastic secretion or paracrine secretion of PTH-related protein, and this usually drives to hypercalcemia, hypercalciuria in those patients. But in this case, this is benign. not malignant one. And just to have some percentage demonstrated, hypercalcemia was in Latvia, it was 10% in hypercalcemia. Hypercalciuria was in approximately 22, and it's usually it's higher in men, regardless of age. So that's might initially resemble sarcoidosis, might initially resemble lymphogranulomatose processes, but histology usually tells that it's still benign process. And with this, I would like to finish my part of the talk. So thank you, Paldies. And I'm opened now for more questions.
Thank you very much, Ieva, for that very interesting and well-structured presentation with concrete guidelines how to handle hypercalcemia. So I think there are questions coming into the chat, and for those who haven't asked a question yet, I would like to encourage you to write a question into the chat. I would like to start with a question. You said that in hypercalcemia, people should receive a lot of sodium chloride, up to 3 or 4 liters per day. Sometimes people use full electrolyte to try to lower the calcium levels. Could you give a little more precise information on why to use sodium chloride instead of full electrolyte?
The main mechanism is that whenever we have hypercalcemia, usually the tubular mechanisms are involved. And in tubules, the sodium chloride transporter is influenced, and usually there's an inhibition of this transporter. So there's always sodium chloride loss, which leads to the fluid depletion. And as far as I know, as far as I also have tried to look in literature, there is no particularly other electrolyte loss noticed. So saline is usually, so sodium chloride is usually lost, and that's what we usually need to replete. And the amount is relatively huge, so we usually advise to start with 1-2 liters as bolus. Of course, seeing if there is no cardiac insufficiency in the background. And afterwards, the usual recommendations go with the 200-300 milliliters per hour as infusion. And the main goal, this of course it goes adjusted based on the diuresis. The main goal is to reach diuresis of approximately 100-150 milliliters per hour. So whatever fluid amount you give, you try to adjust to the diuresis, to match diuresis. But this amount, 1-2 liters bolus, followed by 200-300 milliliters per hour, that's usually enough to lead to hypercalcemia reduction. Okay, and that's why we are try in younger patients. If you can stimulate diuresis just by giving saline, you usually don't need to stimulate or force diuresis. That was formerly known. And honestly, even I occasionally mention, like in older slides when I teach students, this forced diuresis with furosemide. But more and more data are not recommending furosemide use, because that if you don't substitute or replete enough saline, this giving furosemide might lead to bigger trouble, to bigger dehydration and other electrolyte loss.
Okay. Thank you. Thank you very much. I've got a question, if possible. It was just around the use of vitamin D supplementation. So you went through explain the physiology of vitamin D in relation to calcium. How in patients who present with hypercalcemia and are on vitamin D supplementation, is there any role to change that, or it doesn't have any major effect?
I always go, it's very, if they're just elevated calcium and of course I get the history of patient, I get the reasons why he's taking what kind of vitamin D. Is it vitamin D together with calcium, and is it long-term, like we don't have in Latvia ergocalciferol. It's usually like shorter or longer acting cholecalciferol preparations. However, I need to know as a doctor the full history, what's the reason why he is taking. And for calcium, usually the rule of thumb is double check. If there is a slightly elevated calcium levels, hypercalcemia, so no matter what type of the vitamin D is using, check if that's really relevant hypercalcemia, if it's not just like lab mistake. And if it's still elevated, then I might still think, okay, maybe we will just reduce or temporarily stop using vitamin D. And of course, kidney function might be relevant as well. I'm thinking, but the simple way is double check, triple check if necessary. See the full history of patient, why he's taking and what type of medication, supplements, and then to decide the next step. Okay.
Thank you.
I think there are no questions coming from the chat. So there's one question. What would be the therapy at the emergency department if we have a patient, an old lady, 78 years old, with severe bone pain, history of metastatic breast cancer, and ECOG -2, calcium 2.87, and VFR 18 milliliters per minute? I think the colleague didn't write that, but I'm also thinking of maybe mild heart deficiency, seeing the age. So what would you suggest, Ieva?
I missed that. So 2.87 was calcium, GFR was 18. Was there PTH known or?
The colleague didn't mention that. So
breast cancer with calcium elevated and some dyspnea, obviously some elderly lady. Honestly, I would in such patient with combination breast cancer, the dyspnea, calcium 2.87, poor kidney filtration, I would very see how is the overall like other comorbidities, how about heart status, how about heart failure severity. I would also see how about the breast cancer, is it like localized or is it metastatic one? That's for me to decide how aggressively I should approach. And thinking as a humanly, as a doctor, immediately without knowing all the details and asking details, I would go with a very mild hydration, definitely, because I don't know if the GFR is low because of calcium, or is it already known low because of, say, diuretics too much given. That's so mild fluid repletion would be my first initial approach.
Thank you.
There's another question on the chat. Thank you very much. Somebody's interested to find out a little bit more about, malignant hypercalcemia patient with prostate cancer who is on chronic hemodialysis. How do you address these cases?
Prostatic cancer, chronic hemodialysis. I haven't, to be honest, I haven't dealt much with dialysis patients when they are in malignancies and on dialysis. So without checking the literature, I would, my guess would be that in dialysis you can always adjust the fluid balance and how much you remove this calcium, and otherwise prostatic cancer. I would definitely see prostatic cancer very frequently goes with the bone metastasis. I would see if there's no lytic bone damage, and would figure out if there's no necessity of some. Well, if there's hemodialysis, bisphosphonates might be slightly restricted. Steroids might be. I would see how about the metastasis status, if there's necessary. But otherwise, hemodialysis already is helpful in these patients. I'm not sure if that's answered directly to the one who
Yeah.
asked, but that's just without knowing the full history and the some story. Okay.
Thank you very much.
Thank you. Then there is another question from the chat. Somebody wants to know about a metabolite ratio that could be used to assess an elevation of dehydroxyvitamin D, because the colleague writes that there are hardly any elevations seen in patients, and whether you could maybe give us an idea how to approach to the vitamin D levels, whether it's too high, too low, how to handle that.
Wait, I will just need to have this metabolite ratio assessing the elevation, or it's difficult to say, difficult to answer on this. So I will just double check the question. It's in practice, it's rare to find elevation of 125, especially among if there's a deficiency in a general population. And is it granulomatose or not? Okay, I will try. I'm not sure if I will get your question fully. How I would do in Latvia, the problem is that, for instance, 125, it's expensive test. Well, it's 42 euros approximately, and if there's no routine testing in hospitals available. So what we do, if we really suspect that there might be granulomatose disorder, or this might be the somehow calcitriol-driven mechanism, I'm doing completely wrong direction. I usually check how about PTH, and based on the PTH, I try to figure out, is it calcitriol-driven mechanism or not? And very frequently, if I see suppressed, repeatedly suppressed, or with a tendency suppressed this PTH, that gives me an idea that calcitriol obviously could be increased. That's completely wrong way to approach, but this is what I do. Based on PTH, I try to figure out that the calcitriol could be elevated. Otherwise, simple vitamin D and calcitriol, there's no specific publications on these ratios, what could be helpful. And it's also in this sarcoidosis patients, for instance, if there's granulomatose process and too much of the calcitriol, and say even in summer there's low simple vitamin D, it's still there are many publications, and that's what I know for sure, that still some substitution with the small doses of vitamin D with cholecalciferol is necessary. Despite having elevated values, you control the calcitriol by steroids in that case. But if it's like huge deficiency, or you still give a small dose to prevent, say, osteoporosis or the other myopathies, osteomalacia. That's probably again a bit not direct answer, but that's the best what I can give based on the.
Thank you very much. I'm going to continue if that's okay, because we still have some time.
Yeah.
We talked about zoledronic acid. Somebody's asking, how long can you use zoledronic acid therapy for? Is there any considerations kind of longer term?
Which I specifically, I thought to check about duration. I forgot. I checked about denosumab. The denosumab could be given once weekly, initially once weekly for 1 month, and then you just follow with once every 4 weeks. If we are talking about the zoledronic acid use in malignancy patients, usual approach, usually we give it in a generally mild hypercalcemia or the osteolytic damage once monthly. You can give far more frequently, but mostly it gives a bit slow effect. And what we have seen that even if initial hypercalcemia have been very high, critically high, it's still after 2 or 3 or occasionally 4 infusions, this hypercalcemia is relatively permanently long-term slowed down, and you never need to repeat it. So I would go initially, if it's very critical one, 4 point something or 3 point something elevated millimoles per liter, I would go with once weekly, but every time by the end of the week, I would see how is the level, because it works gradually and long term. So even if initially you think, oh, it's just it doesn't work, no, it works. It just goes with this gradual effect. So sometimes even if you initially plan to do it long term, a few infusions are enough.
Thank you very much. Can I follow on with that? So when
Yep.
you test serially to see the response to treatment, is it every 24 hours you suggest to do it? How often do you do it in your practice?
For calcium, I didn't catch the
calcium levels.
Yep.
Calcium levels. So you check them every day, or do you do?
If it's really critical one, I do it once daily and every day. If it's really critical, occasionally we do the Astrup testing. So you see ionized, nevertheless you see it very fast. And it's in a good hands, it's very easy and simple test, and you can other electrolytes and way more information as well. And so normally once daily if it's critical. Otherwise, depends on the every single situation. And what else I do, I always, especially we are talking about hypercalcemia, but especially if we are talking about hypocalcemias, say you see that there's tendency already on lowering of calcium levels, check the albumin, or at least some surrogate markers, say protein, total protein, or maybe see in urine test there's proteinuria, something that guides you that it's not real hypocalcemia. It might be some relative due to loss of albumin or loss of proteins. Okay.
Thank you. Then we might continue with our last question.
Yeah.
Somebody from the chat is interested in sarcoidosis. So she's asking, she has a patient with a healthy case hypercalcemia 2.7 and calcium in urine 24. PHT is normal, and the patient complains about a fever for 1 month, has erythema nodosum on both legs, and cortisol and ACTH levels are normal. So if a sarcoidosis would be assumed, how would you proceed? What would you do? What diagnostic approaches would you choose?
Okay, so regardless the biochemical profile, so it's usually if there's acute like erythema nodosum, we are talking about Löfgren syndrome, about the acute variant of sarcoidosis, and mostly we don't try to confirm this by histology. However, in this complex, when there's also biochemistry involved and still some more detailed, probably, who knows, maybe longer term therapies might be necessary. We try to do the transbronchial biopsy, even if there are no infiltrates. We do the bronchoalveolar lavage and flushing, not flushing, but that's the poor word, doing the lavage and still taking blind transbronchial biopsy. What else we do? Again, many clinics do probably their own mechanisms, but we frequently take salivary gland blind biopsy. And even if there are no other signs in some lungs or the other organs, when you do histology, then the sarcoidosis might be still confirmed. Particularly for this situation, the erythema nodosum and the fever with the hypercalcemia, that's clearly screams for Löfgren syndrome, for acute variant. Okay.
Okay, thank you very much. Maybe I would just close with a very last question. Somebody asks, like you said in your presentation, you told us about a patient that refused therapy, the cancer patient with hypercalcemia, and the colleague asks whether the patient could have refused the treatment because of depression or lack of interest as a symptom of hypercalcemia.
I would think that initially he didn't have any hypercalcemia. That was probably his denial of the diagnosis. What I think, and yes, later there could be depression. However, I'm known in my between my colleagues that I'm still pretty good in convincing patients. If that's the necessary therapy, and if we feel that it would give benefit for this patient, then we would definitely convince him and finding the way how to explain and clarify and everything. In this situation, he was in complete denial, and at some point you just understand if it's a bit palliative and metastatic cancer, you just respect the patient's rights not to be treated. And of course, in being in a legal issues, you need to take this refusal signed up and whatever are the every country's rules for that. But this is a I don't think this is hypercalcemia effect. This is more like his own personality was the one. Okay.
Yeah, thank you. There's also another question I think that is answered by your answer already, because a colleague asks why this patient hasn't been given medication. I think you answered that already as well.
And he received initially bisphosphonates and fluid repletion, and the calcium was for 4.5. It was reduced to 3 millimoles. So it's a huge success in a way. But unfortunately, there is some borderline how much you can give and how long you can give.
Yeah.
Okay.
Yeah. So then I would like to close our webinar because we are now running out of time. We almost spent 1 hour on the webinar, and I would like to thank you very, very much, Ieva, for this very interesting presentation. And I think the questions from the chat also show that there are a lot of insecurities and questions about hypercalcemia, and I think you gave a very good overview about that topic. Yeah, so also thank you for the questions from the audience. And I think we all learned a lot tonight, and I'm happy that you were here, and happy for the next webinar.
Thank you very much.
Thank you very
listeners.
much.
Thank you for the moderators and technical personnel. That's usually the kinks for us to go smoothly. So for everyone, and happy New Year to everyone, and good start and good collaboration for everyone. Okay.
Thank you very much. It was a lovely talk and a lot of learning indeed. So it was very, very useful. And thank you all for joining us this evening. As mentioned before, Professor Gruntmanis' talk will be recorded at a later date. And we just wanted to mention that you'll be able to see this recording and also the added lecture on our YouTube channel. And please follow the EFIM Young Internists group on Facebook profile and share any ideas for any future webinars. We're currently working to try and do them every month. So we're working on a program. But in the meantime, we'll let you know when the next date is. And we always welcome feedback, suggestions for speakers, for topics, to share more learning. So thank you. Good evening, everybody.
Good evening. Bye.
Bye.